Dr. Kayla Pope will be presenting. Dr. Pope is new to Nebraska, has been here since January 1st, so she's kind of learning the Nebraska way of doing things so far. She has a really great combination of being a psychiatrist and an attorney. Dr. Pope is a child and adolescent psychiatrist and the Director of Neurobehavioral Research at Boys Town National Research Hospital. She trained at George Washington University Medical Center in Washington, D.C. with advanced training at University of Maryland and Children's National Medical Center in Washington. She completed a research fellowship at the National Institute of Mental Health, where she studied the neurocircuitry of children with a diagnosis of conduct disorder using fMRI technology. She's a past member of the American Psychiatric Association's Board of Trustees and currently sits on the APA's DSM Oversight Committee. She's also a member of the board of the Accreditation Council for Graduate Medical Education. And as I mentioned, she was an attorney before attending medical school, and she specialized in family law and child advocacy. So with that, I'll turn it over to Dr. Pope.
Good morning. It's a pleasure to be here to talk about an issue which we all, I think, are very aware has become very controversial. The use of atypical antipsychotics, or actually all pharmacological agents in children and adolescents. Let me see if I get my show up here. So, and actually this sort of began when Julie Zito started to look at some of the Medicaid data and started to see some pretty frightening patterns of kids on multiple medications. And then there was a GAO report that was issued last year, which many of you probably have taken a look at, which again has sort of reinforced that we're doing something very wrong with these kids and we need to take a closer look and start to think about healthier options for these children. So I wanted to begin today by discussing a case example, and this is actually a child that I recently evaluated, and I think kind of highlights some of the problems that are built into the system. And it's not just here in Nebraska, this is certainly a national issue, but I wanted to get you all to participate, at least in this first case example, and kind of get your thoughts about what you would do with this child. So the first case is a 7-year-old boy who comes into your office with his mother. The mother is very distraught. This child has become very aggressive in the home, has destroyed the house, has taken a knife after mother, has bitten her lip, and she just doesn't know what to do. So looking at this child, what would be some of the things that you would be thinking about, and what would be some of the questions that you would be asking? What would your concerns be? Yeah.
Do you suffer any trauma anytime?
Trauma, absolutely, very important consideration. Anyone else? Yeah.
I'd ask if he was her biological son or adopted son, and what history there was in the family.
Right, absolutely. Absolutely, family history, genetics, any trauma that might have been associated with adoption or early childhood, yeah.
Composition of the household.
Right, so family dynamics, what's going on with the siblings? Has dad left recently? Is there a boyfriend in the situation? Absolutely,
What
yeah.
interventions she's done at all since it's been 2 years.
Right. So you want to know what the history of treatment has been. Very good. Yeah.
What are his behaviors like elsewhere? Is he doing okay in school? Is he having the same behaviors at school?
Right, so that's actually a very important clue. If it's just in the house, then you start to think about, again, what are the family dynamics, what's going on in the home. But if you're seeing it in multiple domains, it's a little more concerning. Yeah.
If he's been exposed to substances or had any medical trauma, complications, birth, or prenatal.
Right, so in utero exposure to drugs, alcohol, right, other environmental exposures, absolutely. Other thoughts? So you got all the main ones. You want to look at environmental factors, you certainly want to look at biological factors, and then given all that information, you want to start thinking about what could possibly be the diagnosis. So I'm going to give you a little more information about what happened with this case. So when this child came to me, he was already on 3 medications. He was on an atypical antipsychotic to treat his aggression. He was on a stimulant to treat his ADHD, and he was also on guanfacine, which is an alpha-2 agonist, initially designed to treat hypertension, but also downregulates the autonomic nervous system and creates sedation in kids. So it's another way to treat aggression. What this kid also had was severe communication and language disorders, and could barely communicate with me and also with his mom, which was very concerning to me. And this child was becoming so frustrated that he couldn't express himself that he would lose it, not surprisingly. So I contacted Medicaid to see what other services might be available for this child. The options were insight-oriented therapy for a 7-year-old, which I don't know you, but I have yet to meet a 7-year-old with all that much insight. Day treatment hospital or inpatient hospitalization. And if I put him in an inpatient setting, what would happen? He would come out with more medications on board. I didn't think any of those options were really appropriate for this child, but those were the only things that were available to him. So I think this is a systemic problem. These kids end up being in these situations frequently because there aren't good behavioral opportunities available, options available. So we need to be thinking through a lot of this. And not to blame anyone, I think, again, a lot of it is miscommunication. It's not thinking through, it's not understanding where the evidence does support behavioral treatments, et cetera. So a lot of education, I think, needs to be done around these issues. So today I'm actually going to do this talk in 3 separate sections. I'm going to actually begin by talking about development and the importance of prevention and early intervention. Talk a little bit about neurocircuitry, neurotransmitters, and pharmacological agents, and make you all pharmacologists before you leave today. Then we'll take a little bit of a break. We'll come back and talk about disruptive behavior disorders, because these are the disorders that are most commonly being treated with medications in children. And then we'll end with a discussion of mood and anxiety disorders in kids and some of the treatment options there. So in terms of mental disorders and development, I want to talk a little bit about the fact that these disorders truly are developmental and what that means, the prevalence of mental health problems among children, and then some normal developmental differences, because if you don't understand normal development, it's awfully hard to understand pathology and understand it when you see it. So Dr. Insel is the head of the National Institute of Mental Health, and in a recent talk, he made the statement that all mental illnesses we now know are developmental disorders. And that's a pretty profound statement, and what that means is, at birth, we can begin to predict who is going to be vulnerable and at risk for developing mental disorders. And we know that a lot through genetic studies. Pretty much everyone Axis 1 diagnosis now has at least strong evidence that it's genetically loaded, passed from family member to family member. And we're starting out also to identify some pretty good markers for a lot of these disorders. But we also know that having genetic loading does not mean pathology. It creates or conveys a vulnerability, but there's a lot more to the story. And the rest of the story is the exposure that children have early in development, which will really make the difference between whether that vulnerability will be expressed as pathology later in development, a term we are now calling endophenotypes. That's the gene times environment interaction. So what do we know about normal development? So this is actually some really beautiful work done by Jay Geed and his group at the National Institute of Mental Health. And he has actually looked at brain development from the age of 5 to 20. And what you see here is there's an enormous amount of change taking place. And the blue is actually changes in the cortical thickness. And so you can see by the age of 20, the brain has become pretty well developed and formed. But again, across this period of time, there are a lot of significant changes taking place. And what that means is there's a lot of plasticity and a lot of opportunity to do great damage. During this period of time, circuitry is being laid down. You've all heard about synaptic pruning, myelination. I'm going to talk about that a little bit later. But the way the child is going to see the world, how they're going to respond to the world, is being laid down in circuitry during this period of 5 to 20. And it's also during this period that we need to really be thinking about resilience versus pathology. So does early intervention work with children? Has anybody here ever heard of the Harlem program, Harlem Project? Yeah. Okay, so this was actually a very resource-intensive, labor-intensive initiative to take some of the highest risk kids in the Harlem community and see if they could provide, if they provided everything, would it really change the outcomes for these children? And by everything, I mean parent training, education, employment assistance, mental health, medical care, school involvement, et cetera, the full panoply of interventions. And everything from prenatal period all the way through college. And what were the results? Well, pretty striking, I think. 100% of the kids were ready for school. 100% of third graders were at or above state scores for math. And again, remember, these are kids in Harlem, the highest risk kids probably in the whole state. And 90% of the high schoolers were accepted at one or more colleges. So now that we have some sense that prevention really does work, even though it can in fact be very expensive, I think we need to ask ourselves, how good of a job are we really doing? In one study, pretty shocking evidence that 50% of the kids that ended up committing suicide had never seen a mental health provider in the year prior to their death. So one thing we can start to think about is, well, how do we identify these kids? Where can we go to identify these kids? And I thought this study was actually pretty interesting. This is done in Wisconsin from the period of 2005 to 2009. What they did was comprehensive mental health screening. And lest you think this was a really intensive undertaking, in fact, it wasn't. All these kids were screened using a computer-based assessment, which took less than 10 minutes. And over that period of time, they screened about 2,500 kids. Of all these kids, about 20% of them were deemed to be at risk for one or more mental health disorders. And of those at risk, only about three-quarters had, about three-quarters of them were not receiving any services. So that's pretty significant. So what they did was they then referred kids either to community-based programs or school-based programs, and the more severe kids were actually sent out to the community. The less severe kids were receiving school-based services. The unfortunate part about it is those kids who were actually being referred out to the community really were not following up with services. So, again, their problems were not being adequately addressed. And the kids referred to school actually went to one or more sessions. So anybody who has ever worked in a school or worked with kids, the ones we see are always the externalizers, the squeaky wheels, the ones that are being aggressive, acting out. But the ones that we don't see, and this is where I think school-based assessment really would have great payoff, are the internalizers, the kids with anxiety disorders and depression, and suicidal ideation. And as these numbers reflect, there were a lot of kids that were being missed that would not have been picked up if they weren't actually doing this comprehensive screening in the school. So I want to talk just a few minutes, since I'm an imaging researcher, about how we use neuroscience technology to understand development, both normal and pathological. I'm going to talk about a couple of different modalities that we use for research, structural and functional MRI, and then to say a few words about some behavioral studies, which help to really highlight the differences between normal and pathological development. So a question for the audience: is it safe to use MRI technology with children? Any guesses? Well, yes, in fact, it is. It's very safe. It's minimal or no risk. And there's actually several decades of research now to demonstrate that. The worst side effect a child will ever experience is a little bit of headache. If they do have claustrophobia, sometimes that will induce a claustrophobic or an anxiety reaction. But other than that, it's actually been proven to be very safe and effective. So normal developmental differences between children and adults. So again, needing to understand what normal development is so you can assess pathology. And one area where we've had a lot of really interesting research is the differences in executive functioning. And these are things like impulse control, working memory, being able to follow through, organize material. And we know that through adolescence into early adulthood, these areas of the brain are still coming online and still developing. So it is not unusual for a kid to act impulsively. But of course, it's always along a spectrum, and those are things that you just need to take into consideration. We also know that adolescents are far more emotionally reactive than adults and have less ability to actually control these behaviors. Again, this is largely due to brain maturation in the same area as the frontal lobes, and having that top-down control over the limbic system area of your brain, which actually is involved in emotional reaction to your environment. Some areas in particular where they have problems, response to threat, facial expressions, and understanding motives of self and other. I'm actually going to go through a little bit of research that demonstrates this. So a question for the audience: from adolescence to adulthood, does cortical thickness increase, decrease, or remain unchanged? Increases. So it actually decreases. And why would that be? Your brain actually is becoming far more efficient. So as you lay down patterns and you make decisions about how best to approach the world, you kind of get rid of all those other neurons that you really don't need because you already decided what you're going to do. There's really two different processes that are at play here. One is myelination, and anybody that knows anything about electricity, it's all about insulation. And as we insulate these axons, they actually send their message far more efficiently, and it speeds up brain processing, etc. And then synaptic connections, as I said, those neurons that we're not using, we tend just to get rid of, and it makes the brain far more efficient. But if you're laying down the wrong circuitry, it also makes it far more difficult to undo. So let me see if I can get this to play. maybe if I back out. Okay, I guess not. Okay. Oop. Sorry. Okay. So again, this is a slide I showed previously, and again, the cortical thickness of the brain is actually changing markedly over this period of time from 5 to 20, so that by age 20, you're really pretty fully developed, and the cortical thickness has been established for probably the next several decades of your life. So some of the other technology that we use to help us understand brain development and brain functioning is something called diffuser tensor imaging. And what DTI does is, rather than identify just those discrete areas of the brain that are in operation at a particular point in time, it helps us understand how these different parts of the brain relate to each other, so how the circuit is actually functioning. And we do know now that there are significant changes in the connectivity between, or differences between adolescents and adults, especially in those areas that are involved in impulse control. And by the age of 19 or so, these have been fully matured. Also some differences in the way kids integrate information. And again, by late teens, early 20s, these circuits are being laid down and have actually reached maturation. Functional imaging, again, has also been used. And as I was mentioning before, kids are far less efficient in thinking through problems and solving problems, and that's actually been demonstrated using fMRI technology. They also have a much harder time following rules and switching strategies. So working with kids, that it's always best to prepare them when a transition is coming out, giving them time to think about it and get ready for the next activity. And this has actually been demonstrated through neuroscience imaging. And then also with emotion, as I mentioned, kids have a tendency to see threat where it really doesn't exist. And it isn't until late adolescence, early adulthood that begins to normalize. Less able to actually process faces accurately, and are less capable of really understanding their own thoughts and feelings, and certainly have less insight into the emotional experiences of others. And that probably comes as no surprise to anyone. I mean, a lot of the science is really just sort of proving the obvious, but important to actually understand it biologically. So in summary, we know that there are significant differences between children, adolescents, and adult, and there's a significant amount of change that's actually occurring over this period of development. We also know that children are oftentimes at risk, especially the internalizers, the kids with depression, anxiety disorders, but go unidentified and do not receive services. And we also know that early prevention and early intervention does work, is very effective. So my recommendation, every year kids go and they have a medical screen done before they can start school. Why not also include a mental health screen? Less than 10 minutes, computer-based, identify these kids. I think over the long haul, we would save a lot of money, certainly in terms of long-term mental health care, and certainly something hopefully Nebraska should consider. Also, I think there's a need to really think about where is the appropriate place for care for children. We know that younger children do really well in school-based programs, but adolescents not so much. They don't want their peers to know that they're getting any kind of mental health treatment. And there's a lot of research to support community-based care for this part of the age group, with this age group, adolescents. And also clearly need for better coordination between schools, healthcare providers, and parents. Okay, so now I'm going to do the pharmacology piece of this talk. And first I wanted to just show you a little bit about how cells communicate with each other. So this is how the chemical message is sent from one cell to another, and is really the most basic unit of the neurocircuitry process. So as you'll see here, there's one axon, one cell communicating with the other, and in between is something called the synaptic cleft, and in this area is where all the neurotransmitters are put into the space and then picked up by the cell on the other side of the space. So when we talk about pharmacology for mental and behavioral disorders, there are really only 3 basic neurotransmitters that we operate on. A little bit tweaking around the edges, but these are really our 3 main agents. So dopamine, which is involved with cognition, executive functioning, and the reward system. Dopamine is highly involved in abuse and the reward circuitry. Serotonin, very involved with mood and anxiety, regulating mood and anxiety. Also, high density of serotonin receptors in the GI system. And then norepinephrine, which is really involved with arousal. So I want to just give you an idea of how broad these pathways really are. So when we treat a child with a medication that works on dopamine, it's working on a lot of the brain. I mean, these are really like sledgehammers. They aren't chisels. They don't work on the particular part of the brain that we think is dysfunctional. So as you can see here, dopamine actually it covers all of the frontal cortex, and serotonin is actually even more broadly distributed throughout the brain.
Is that color coordinated?
I'm sorry?
Is that color coordinated?
Color coordinated?
Oh, you're on your diagram there?
Yeah, so the serotonin is the red, and you can actually see the functions are mood, memory. Let's see, actually. Yeah, and the blue is the dopamine pathway. Okay. And here's norepinephrine. As I said, it's really involved with arousal from the brainstem, cerebellum to the frontal cortex. And we'll talk a little bit more about that later. So in terms of medications, again, we can only do so much. We can increase dopamine or we can decrease dopamine. And dopamine enhancers, these are the stimulants that we often use with ADHD, to treat ADHD, things like Ritalin and Concerta. And they increase the amount of dopamine available, and they do operate on the frontal cortex and increase and enhance executive functioning. Atypical antidepressants are also sometimes used to modify or increase the amount of dopamine available, Wellbutrin being the most commonly used, and it also operates on norepinephrine. Dopamine inhibitors, these are the things like psychotics and atypical antipsychotics. What they do is they actually decrease the amount of dopamine available in the brain, initially designed to treat psychotic symptoms, but as you all know, we are now increasingly using these to treat aggression, but there's really no clear mechanism for why they would be effective in treating aggression. They also are known to have significant side effects, including a lot of sedation. For serotonin, we either, again, can increase or decrease the amount of serotonin. There really aren't any serotonin decreasers that we use, but we do use a lot of medications to increase the amount of serotonin available. And these are called serotonin reuptake inhibitors, things like Prozac and Zoloft. And these are frequently being used to treat both depression and anxiety. More recently, we've been using some combination medications called SNRIs, which operate both on serotonin and norepinephrine, increasing the availability of both. And these are also increasingly being used for depression and anxiety. Other medications that are sometimes used to treat mental health disorders in kids are mood stabilizers, things like lithium and Depakote, and again, frequently being used to treat aggression, although the mechanism, again, by which they operate to treat aggression is not known. We do know that they are very sedating, so it is quite possible that that is the way that it is being used to treat aggression. They were initially designed to treat seizure disorders in kids. So, any questions thus far? Yeah.
What are some examples of the dopamine
Inhibitors, so Abilify, Zyprexa, Seroquel, the antipsychotics, Haldol, Thorazine, yeah, Risperdal, commonly used. Any other questions? Okay. So actually I thought we would just take a quick break here. I'm sorry, go ahead.
Well, I had a case where Depakote was used with a child with ADHD, and what's the idea there?
So Depakote would not commonly be used to treat ADHD. I'm sort of surprised that they would use that. I mean, generally you would start with a stimulant, something like Adderall or Focalin or...
It was used in combination.
Okay, so they were probably treating something in addition to ADHD. Was the child also quite aggressive? Behaviorally dysregulated?
Could be.
Yeah. Yeah, so that would be my guess, which wouldn't make a lot of sense. Yeah.
What, are you familiar with Zyprexa, and is that one of these kind of medications?
Yeah, so Zyprexa is an atypical antipsychotic, and again, what it does is it decreases the amount of dopamine in the brain. And oftentimes what you're going to see is something like Zyprexa being used with Adderall. And what you have then is one medication increasing the amount of dopamine, the other decreasing the amount of dopamine, which kind of creates chemical chaos, which we really don't know the long-term implications of that. Any other? Yeah.
Do you see the norm that the schools are cooperating with the medical field, completing checklists and that sort of thing when the student is changing medication?
Yeah, so I know a lot of times they'll use like a CBCL or something with ADHD medication stimulants to see whether there is any benefit in the classroom. Yeah, I mean I'm assuming it's being done regularly, and it's very helpful. Probably, yeah.
Are any of, kind of answering my own question, but very few of these drugs are ever designed or tested to
Right.
to be effective in children, so it's kind of a crapshoot when
Right.
when they're prescribed.
Right, so most of these medications are being used off-label, and they've never been tested in children in terms of safety or efficacy. And oftentimes when they are testing them, the tests are really limited to behavioral observations of the target behavior, and they're not measuring things like sedation, cognitive, interference with cognitive functioning, etc. Yeah. And there's absolutely no data looking at long-term implications for development. Yeah. Any other question? Okay. All right, so we'll take a quick break and then we'll go on to the second section.